Once everything is healed well, the lab sends you the initial coping trials. You need to fit these coping trials to see for fits, for individual fits, collective fits, margin extensions, overextensions, the gingival contour for the pontic, clearance in centric and eccentric movements. So you could do it one arch at one time, leaving the provisionals back. You could do both arches together. It depends on what is suitable for you, what is convenient, how you have been trained to work with these. And then once you are sure that the fit is good individually, this is very, very important step because this will make you understand what is going to be the final result as well as the long-term success of whatever you've done. So once you do these coping trials, then you will move on to the next step where you will get your final restorations. So you could do the provisionals, you could place the provisionals on one arch, then the second arch, and take it. You could use occlusal stops on distal copings to provide a stop for vertical dimension. You could do so many things, take a fresh bite record for the laboratory, and then you could do it on metal to metal or provisionals to metal, depends on what is your modus operandi and how do you want to finish the case. And then you will restore because you have already benchmarked the vertical in your provisionals. So you could use the provisionals again to give you sufficient information to re-record the same vertical with your provisional restorations. Finally, when you place the final restorations, you are looking at a very different scenario. Well, cementable restorations, let's talk about it. And now from last 25 years that I am been involved in implant dentistry, 95% to 98% of all the restorations done are cementable restorations. And I'm very happy to tell you that the success rate has been immense. Great success rate, more than 99% success rate in the mandible and probably 98.5% success rate in the maxilla over the last at least 15 years of observation that we have with multiple cases done. Now, the very fact that fear psychosis which has been created, that screw retain restoration means you are eliminating the possibility of cement going and damaging the peri-implant structures, is ridiculous. If you're careful, if you use the right cement and the right quantity of cement, you can eliminate this cement. If you're a great clinician, you will always find this cement very easily. Also, you need to understand, according to the merit of the case, you decide whether you want a cementable or a screw retain. Many times a screw retain will have a non-engaging attachment. A cement retain has a properly engaging abutment. So it's very important to understand the biomechanics that you're dealing with when you're doing multiple restorations. I'm not against screw retain, but I'm against the excessive use of screw retain in simple cases which can be done very predictably with cement retain restorations. And the concept that the newer generation suddenly seems to have that cement retain is the worst one. If you look at all the researches and even the latest research on cement retain versus screw retain, the success rate of cement retain is much higher than the success rate of screw retain. That's what our patients want. So remove all excess of cement. There should be no leftover cement subgingivally. Block and seal all excess holes. Re-evaluate occlusion after cementation. You need to understand what kind of occlusal scheme you would like to give. And this is just a recommendation. It could differ from case to case. So if you have a single tooth solution, you could have a light intensity contact, which is to the range of 30 microns, and a maximum intensity which comes in contact. So when you ask the patient to bite hard, he should be in contact, and light touch, you could have a micro gap there. Micro gap is very, very small, 30 microns. So there is contact, but there is not really too much contact there. A little relief from natural teeth. This goes for an implant solution. For fixed prosthesis of more than two implants, again, it's very similar to a single tooth. When the canine is present in a fixed prosthesis, it's also very, very similar. And when the canine is absent, it's also very, very similar because the excursion is in group function now. When you have bilateral free-ending prosthesis with implants, you have to keep it in contact. And then you try to end it with a group function kind of occlusion. If the canine is involved, but if the canine is not involved, you will still maintain a canine guidance there. Sometimes people also maintain canine guidance if your implant in the canine is very, very rigid, very firm, very long, very wide. So it all depends. It's multifactorial. It's not one chart that you can follow in all cases. You have to use your mind, and you have to be very mindful in understanding what you need to apply in which case, and that's clinical dentistry. And the mind is very important, the presence of mind that you want to keep for all cases. When it comes to implant tooth supported, you could have more clearances to the tune of 50 microns with contact, and in excursion movements, no contacts, depends. And completely edentulous cases, you will definitely have contact and you will have mutually protected occlusion whenever you want to. Although, if it is a fixed prosthesis with multiple implants, you can even give a slight canine guided occlusion. As long as the disclusion is less than a millimeter on the non-working side, or the working side less than a millimeter, and about a millimeter 0.1 on the non-working side. That means the canine should not get overloaded. So occlusion is important, but also is the amount of disclusion to verify the load that you are giving to that tooth in that particular excursion. So disclusion on protrusion, mutually protected or canine guided occlusion must be designed considering tooth and implant supported restorations. In case of purely tooth supported restorations, group function occlusion may be selected. It all depends on what the situation is. I think canine guided will be the best occlusion whenever you can, as long as you keep the amount of disclusion in 2 millimeters of canine guidance to minimum at the first molar region, both in working side as well as non-working side. So it's very, very important that you are keeping the guidance and disclusion and disclusion of posterior teeth or lateral excursions. You need to understand that when we chew, we do not chew in the way we ask the patient to guide his teeth. So we want to check anterior guidance, we ask the patient to move his teeth in the front, or when we ask him to move on the lateral side, it's checking lateral guidances. But when you actually chew, it's the reverse of that. So when you chew, you start with your front teeth, and then as you move in, you rotate, you hit the canines, and then the canines push the jaw on the other side, then the other canine pushes on the other side. So this is a mutually protected occlusion, giving relief to certain teeth in certain times of excursion. The relief to the teeth, to the periodontal ligament, everything. So in the post-operative OPG, you see multiple implants, multiple teeth. But understand, when the jaw is going to be moved in multiple directions, it's dynamic occlusion. You need to understand how much of relief you want to give for the implants, and how much of relief you want to give, and how much of occlusion you want to keep for the natural teeth, especially when it is a periodontally compromised tooth. So for a healthy tooth with great amount of bone support, the loading will be a little different compared to a slightly periodontally compromised tooth and to an implant. Now there are three different shifts here. The periodontal ligament moves to a certain extent, and the implant moves to a much lesser extent. And the periodontally compromised, slightly mobile tooth moves to a certain extent. How do you calibrate this occlusion? It's very, very important. So, using different grades of articulating paper, you can relieve the excess wherever you want in whichever restorations. You have to understand that the natural healthy tooth can bear slightly more load than the slightly compromised periodontal tooth or the implant, which has got minimal movement because of no periodontal ligament. It only moves in the micro gap. And that's why both the axial and the lateral movements are going to be lesser than the periodontal ligament movements. So the load factor has to be controlled there as well. It's very important that you review the patient every 6 months or 1 year to see whether there is any gingival inflammation, because gingival inflammation can be because of bad margins, it can be improper hygiene maintenance, or it can also be a combination of increased occlusal loading. The first signs of increased occlusal loading can be seen in the periodontal environment, the peri-implant environment. So you can expect peri-implant mucositis to also happen because the occlusion is unfavorable. It can also happen because the emergence profile is inadequate, the hygiene maintenance is multifactorial. The problem in dentistry is multifactorial, and that's why a holistic understanding of everything in dentistry is important to deliver a case. And that's why all specialties have to struggle to understand what the other specialties have to say and correlate that to what they do in dentistry. So in our restorations, periodontal health is ensured by maintaining the biologic width, margin design and margin placement. Avoiding overextensions or over-contoured margins is very important. And for teeth with furcation involvement, restorations should be designed to ensure cleansable contours or cleanable contours. Cleansable is when you can maintain it on your own. Cleanable is something which you can take efforts with. So both of them are important. Flossing, maintenance with use of mouthwash, and a regular mouthwash can be anything like essential oil mouthwash. You don't have to use a medicated mouthwash for regular use. It can cause resistance. Proper brushing, visit to a dentist regularly, once a year, once in 6 months in the initial 1 year or 2 years, and then once in a year. If it's reviewed well, use of interdental brushes, very important. Post-surgically, you will use a chlorhexidine kind of mouthwash, 0.2% for about a week or 2 weeks. But after that, you will go for an essential oil or a non-medicated mouthwash. So the small charts here tells you about flossing, spiral interdental brushing, 50% less, and embrasure filled with papilla or no papillary fin. You will be using an interdental brush. So you will use different approaches so that you can go within that space and clean. You can use a water floss or an air floss, which will allow you to clean, allow your patient to clean very predictably every day. You could use a mouthwash in that as well. And then, of course, you see the dentist regularly. Now, what does the dentist see when he sees the patient? How does he know that there is a periodontal disease happening? Is it only on clinical science? No, it's on probing depths, it's on radiographical interpretations, it's on occlusal science. So all of this together, listening to the patient, whether he eats on both sides comfortably or not, what is he doing? Looking at plaque accumulation in one particular area, which suggests that he is not using that side. Looking at over-contoured restorations again. signs of peri-implant mucositis. All of this is going to be an important part which is to be executed by when you do examination. Maintaining this chart is also important for long-term success. Listen, people come to us for a long-term solution with implants and full mouth rehabilitations. It's our duty to maintain a maintenance chart so that we understand what was the problem and what needs to be done additionally by the patient to maintain better, or what needs to be done by the dentist to modify so that the patient is helped to maintain it better. And then you're happy to see a 10-year post-op. You will see little bone loss. You will see the gingival health is good. But it's very important that the long-term success of full mouth rehabilitation is gauged by you. Optimal function, reasonably good aesthetics, maintenance of the periodontal health, quality of the restorations, occlusion and stomatognathing balance. All these factors needs to be reviewed periodically to really make your solutions long-term success. And with this, we have the last question and answer session.